Jamile, what are your goals of therapy for patients with higher risk MDS, and how does that differ from your goals for lower risk MDS?
Well, if I have a patient who has high risk, I think the very first thought that comes to my mind is disease control. I want to control this disease and hopefully get a response and delay leukemia evolution, and hopefully prevent transfusions, infections, etc. So in that sense, as opposed to me reevaluating this low-risk patient, how long can I monitor them without therapy? In this case, it's probably the other way around. And also the second thing that comes through my mind is this patient a transplant candidate? You know, because clearly even with the best agents you have, when you have something that with a median overall survival of about, 50% at 24 months, this is no cure, and hence you have to have an alternate for your patient, though again, as you all would agree, the percentage of patients who can undergo transplantation is relatively small. Though having said that, with the advent of reduced intensity transplant, it's probably a worthwhile discussion to have with the patient, potentially having them see a transplanter and then determine whether or not they have a sibling or a matched unrelated donor. But again, it's somewhat problematic because let's say in the best case scenario, you have a younger patient in their 60s perhaps with a perfect donor, then the gray areas happen such that would you actually treat them? Would you induce them into a CR? Would you send them to transplant immediately? So then all these things tend to be issues that we have to think about. But this is pretty much the standard of what I would do.
And what doses do you use of hypomethylating agents and what schedules?
So usually for high risk, 75 milligram per meter squared for 7 days. Now we don't
for
have clinic hours, yes, for AZA, and then for Dacogen, 20 milligram per meter squared for 5 days. For high risk patients, we usually do the 5, 2, and 2 for AZA, and then the 5 days for Dacogen. I must confess that sometimes for people who have high multiple comorbidities, transfusion dependent, etc., and cannot receive treatment outpatient, I end up hospitalizing them for 3 days of Dacogen. Sometimes that's easier logistically.
Yeah, sometimes it is. People travel a long distance where, we're not all in New York City where people can sometimes hop on a subway or get caught in midtown traffic on their way to the treatment center. So sometimes you have to do that when, particularly, we'll have some patients who travel hundreds of miles to come to our treatment center and need to work out those logistics. Rami, Jamile brought up allogeneic transplant, which of course is the only curative therapy for MDS. What criteria do you use for recommending that a patient go for transplant?
Right. So obviously, when I look at this, it's a very complex thing, and I learned over time that this is a discussion with the patients, that patients have to weigh on the decision when going to transplant. I look at two things, obviously the disease risk itself. There had been those decision models published by Dr. Cutler and other groups looking at the timing of transplant, lower risk versus higher risk. So in lower risk, the maximum gain of survival or taking advantage of the transplant is holding on the transplant. In higher risk, the maximum gain of survival is to proceed to transplant. So one factor I look at is the disease risk. So if they're higher risk disease, those are patients that, as mentioned, have a median survival of less than 2 years. I think the whole thing is really weighing the benefit and the risk of the procedure. No matter what we talk about transplant, we are always talking about around 20% transplant-related mortality. The cure rates vary. Yes, in lower risk disease, we may have a 60-70% cure rate, but there is a 0 chance of mortality in the coming 2 years in lower risk, so we don't take the action. In higher risk, there is 40-50% mortality in 2 years, so you can justify the transplant. The cure rates are a little bit less. So in general, higher risk from disease point, I think those are the patients we discuss with them directly the transplant. The lower risk disease, if they are younger patients and they've gone through all the standard treatments and clinical trial, I think it's reasonable also sometimes to discuss the transplant with them. If you have somebody in their 50s, had ATG, hypomethylating agents, enrolled on a couple of trials, and there is no other option, I think those patients are definitely worthwhile discussing them. Then the other thing is basically, obviously, the patient factors. Age per se, I'm not sure that there is nowadays cutoff for age because we say age is function. So we do consider sometimes patients up to age of 75. Most of the data are actually on patients either below 55 or 65. And then obviously the comorbidities, the availability of the donor. The way I discuss it with patients, I say, like, let's set up what are the goals. If somebody is young, I think sometimes it's much easier with higher risk disease to say transplant is the only way. Somebody who's 50, expected to live without MDS to age of 80, there is a 30-year potential gain in survival. But let's say our average patients who are like 69 or 70, excellent shape, no comorbidities. Like the way I discuss it with patients, I say we need to set our goals. In general, somebody who's 70 is expected to live to 80, 82, right? That's the average population survival without MDS. With MDS, a higher risk disease would have maybe, 2 years survival, the best. Actually, the medians come probably the same, transplant or not transplant. But basically, those patients are losing 7, 8 years of survival because of the disease. But then the procedure itself is intense. A month in the hospital, 2-month apartment across the hospital, a 2 or 3 years quality of life affected. So the end gain of a good quality of life could be only 2 or 3 years for somebody in their 70s. So I always try to explain that. And I tell the patients, what's your goal? If somebody says, my goal, I want to make it to 85 because that's what I want to do, I'm willing to take risks, I say, you have your answer. If somebody says, no, I value more quality of life and I want to see the graduation of my grandson next year and not be on all those treatments, you have your answer. So I think it's always weighing those benefits and risks. But definitely we look at the disease risk. The patient age still weighs, although more data suggesting that age per se does not predict the outcome. The functional status of the patient, the comorbidities and availabilities. Availability of donor, which is also now changing with haplo transplants and other things. In general, as you mentioned, like when we look at our database, as much as we are aggressive in transplant, in our MDS patients, less than 10% were transplanted. 50% of the patients that we sent to transplant with intent to transplant ended not getting a transplant.
And I think that's a critical message as well. If you look at the population, fewer than 5% of patients with MDS are even approached about a transplant, or is it even discussed. Even at our centers where we're geared up to transplant and look at it as part of our algorithm, as soon as a patient is diagnosed with higher risk MDS to consider transplant, it's still less than 10% because of a lot of the limitations and factors that you mentioned.